Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the connective tissue disorders, that is the Reiter's syndrome. So, if you see the basic definition of the Reiter syndrome, it is also called as reactive arthritis because the joint involvement is very common in these patients with the Reiter syndrome. So, this reactive arthritis, it is precipitated by antecedent gastrointestinal and genitourinary infection. Okay, so this is precipitated by antecedent gastrointestinal and genitourinary infection. So, in the sense, there will be a prior or past history of gastrointestinal and genitourinary infection, and the manifestations will be in the form of asymmetric sterile oligoarthritis. So, asymmetric in the sense the joint involvement will not be bilateral, right? The joint involvement will be unilateral. Okay, so this asymmetric sterile oligoarthritis. So, when I am using the word oligoarthritis, the number of joints which are involved is less than or equal to 4 joints. Okay, and typically the joints of the lower extremities are affected. Right. So, this is one of the very important manifestation of the Reiter syndrome or reactive arthritis. And this arthritis, it is frequently associated with enthesitis. Right, it is frequently associated with enthesitis. Now, what do you understand by the term enthesitis? Enthesitis is the inflammation of the tendon at the site of insertion over the bone. That is called as enthesitis. Now, in these individuals with the Reiters, they also have the extra-articular manifestation. And these extra-articular manifestations, they include urethritis, then followed by that conjunctivitis, right? Next, followed by that, there will be also other ophthalmic manifestation in the form of uveitis. And so, this arthritis, urethritis and conjunctivitis, these three are very common manifestation in case of Reiters or reactive arthritis. And apart from that, there is also the skin manifestation. And skin manifestation in Reiter syndrome will be in the form of a rash, right? And the name of this particular rash, it is keratoderma, blennorrhagica, right? Keratoderma, blennorrhagica. So, that is the rash. And what is this keratoderma, blennorrhagica? Keratoderma, blennorrhagica or keratoderma, blennorrhagicum, it is the hyperkeratotic vesicles over the palms and as well as soles, right? I will be showing you that image as well. And along with that, in these individuals, there will be also mucocutaneous lesions. Right, there will be mucocutaneous lesions. So, these are the extra-articular manifestations. Now, after having discussed about the extra-articular manifestations, let me discuss the HLA association in patients with the Reiter syndrome. See, this reactive arthritis or Reiter syndrome, it occurs most commonly in young men. Right, it occurs most commonly in young men and it is associated with HLA, that is HLA-B27. Right, that is HLA-B27, and this is seen in 80% of white patients and 50 to 60% of the blacks. So, the incidence, it is more common in whites than compared to that of blacks. Okay, so that is about the HLA association and as well as the age distribution. And let me just show you a question on how the question can be asked on the Reiter's or the reactive arthritis. So the question on the Reiter syndrome can be asked in the following way. All are true regarding the Reiter syndrome except the interstitial lung disease, conjunctivitis, occurs after the sexual contact, ulcers on the palm and soles. So this is the question, right? Let me just discuss in detail about the Reiters and come back to the same question. So the triad is very important in case of Reiter syndrome. And what will be the triad? That includes asymmetrical arthritis, then conjunctivitis, and then urethritis. So this is a triad that you will see in patients with the Reiters or the reactive arthritis. And this particular triad, right, this particular triad, it occurs some weeks after either a dysentery or venereal infection. Okay, so this particular triad, it occurs weeks after either dysentery or venereal infection. So that is about the etiology for the Reiter syndrome, but this is more common in individuals who are having the HLA B27. Now, followed by that, you need to know that we have two forms. That means we have the dysenteric form of Reiter's or reactive arthritis, and then we have the venereal form of the Reiter's or reactive arthritis. So we have two forms of the Reiter's. One, it is the sexually transmitted form, right, and the other we have the dysenteric form. So these are the two forms of the Reiter syndrome. Now you take the sexually transmitted form, right? Sexually transmitted form, which is nothing but your genitourinary infection. This is especially with Chlamydia trachomatis, right? The organism here is the organism here is the Chlamydia trachomatis, and this organism have been found to trigger the reactive arthritis, whereas the dysenteric form, which is nothing but the gastrointestinal infection, that is with Shigella, Salmonella, and Campylobacter species. Alright, so this is the dysenteric form. So these are the two forms. Now in these individuals, which is the most common organism associated with reactive arthritis? So options are Staphylococcus, Shigella, Chlamydia and Yersinia. So we have discussed two forms. One is your sexually transmitted form, secondary to your Chlamydia trachomatis, and dysenteric form, which is secondary to your Shigella, Salmonella and Campylobacter species. Now among these, which is the most common is the Chlamydia trachomatis. That is, the sexually transmitted form is the most common. Now, if you just see the detailed description of the individual clinical manifestation, one, we have discussed about the arthritis. So what is the type of arthritis in these individuals? That is asymmetric arthritis. Right, the individual will have the asymmetric arthritis, and this arthritis, it primarily involves the joints of the lower limb. Right, it primarily involves the joints of the lower limbs, and the affected joints, they are very painful. So it is a painful arthritis, right? It is a painful arthritis. And there is also dactylitis. So what do you understand by this word? Right, what do you understand by this word dactylitis? So dactylitis is the inflammation of the digits where you have a sausage shaped digits. That is what is your dactylitis. And even the affected finger, there will be diffuse swelling of the solitary finger or toe. Okay, there will be diffuse swelling of solitary finger or toe. Okay, so that will be your arthritis. And apart from that, we also have discussed that these arthritis, it is associated with the enthesitis. So this is about your asymmetrical arthritis. Then you take the urogenital lesions, and these urogenital lesions, the manifestation will be in the form of urethritis, prostatitis, right? Then followed by that, in females there can be cervicitis, right, where there is inflammation of the cervix, and then salpingitis. So if you take this salpingitis, okay, so it is the inflammation of the fallopian tube. That is what is your salpingitis. So these are the urogenital lesions: urethritis, prostatitis, cervicitis, and as well as the salpingitis. Then you take the ocular lesions. Ocular lesions will be in the form of conjunctivitis, and then followed by that anterior uveitis. Okay, so these are the ocular lesions, conjunctivitis and as well as the anterior uveitis. Then followed by that, we also have the mucocutaneous lesions, that is the skin lesions which I was discussing. So if you take the skin lesions, the mucocutaneous lesions, so these mucocutaneous lesions will be in the form of the oral ulcers, right? Number 2, we have the hyperkeratotic lesions which I was just discussing, and that is keratoderma, blennorrhagicum, right? Keratoderma, blennorrhagicum. So what is this keratoderma, blennorrhagicum? It is the hyperkeratotic vesicles over the palms and soles. Right, hyperkeratotic vesicles over the palms and as well as soles. Next, the another important mucocutaneous lesions is the circinate balanitis. So what is this particular circinate balanitis? It is the presence of vesicles on the glans penis that form painless superficial erosions. Okay, so the presence of vesicles on the glans penis, that is what is called as your circinate balanitis. Okay, so here there is formation of painless superficial erosions over the glans. That is what is your circinate balanitis. And what will be the rare manifestations? The rare manifestations will be in the form of cardiac conduction defects. Right, that will be in the form of cardiac conduction defects, and aortic abnormality in the form of the aortic regurgitation. And there will be another important rare manifestation will be central nervous system and the peripheral nervous system manifestations. Okay, so this is about the rare manifestations of the Reiter's or reactive arthritis. So most common will be your asymmetrical arthritis, then followed by that urogenital lesions, ocular lesions, mucocutaneous lesions, and then some rare manifestations. Now let me show you the keratoderma, blennorrhagicum, right? So this is the image of keratoderma blennorrhagicum, where you have the presence of the hyperkeratotic vesicles over the palms and as well as the soles. Okay, next. So coming back to the question what I have shown you in the beginning, all are true regarding the Reiter syndrome except interstitial lung disease, conjunctivitis occurs after the sexual contact, ulcers on palm and soles. So the answer here is the interstitial lung disease, right? So interstitial lung disease, it is not the manifestation of the Reiters or the reactive arthritis. Okay, and another question is keratoderma blennorrhagica is typically seen in rheumatoid arthritis, psoriatic arthritis, reactive arthritis, ankylosing spondylitis. So keratoderma blennorrhagica, it is typically seen in the reactive arthritis or the Reiter syndrome. Now, how to diagnose this particular Reiter syndrome? So you need to take the culture, right? The culture, it is taken from the urethra or cervix or the throat. So urethra or cervix or from the throat. So from either of these structures, right, the swab has to be taken. Right, from either of these structures, the swab has to be taken, and then you need to do the culture of the causative organism. So the culture has to be taken from urethra or cervix and the throat, right? So these areas may be swabbed in an attempt to culture the causative organism, right? And apart from these, cultures may also be carried out on urine and the stool samples. Right, cultures have to be done on the urine and as well as the stool samples. And not only that, from the joint you have to take the synovial fluid, that also has to be sent for the culture. So the fluid, that is the synovial fluid, right, that has to be sent or that has to be obtained by arthrocentesis. Right, that has to be obtained by arthrocentesis. This has to be sent for the culture and sensitivity. Okay, next, and apart from that, a blood test for the genetic marker, that is HLA-B27. Right, the HLA-B27 may also be performed. So this is how you will diagnose the Reiters or the reactive arthritis. Now, after having discussed about the diagnosis, let me tell you what is the treatment. What is the drug of choice? Drug of choice is the NSAIDs. NSAIDs have been the mainstay of therapy. Right, the NSAIDs, they have been the mainstay of therapy. Now, what about the antibiotics in the reactive arthritis? Antibiotics given at the time of non-gonococcal sexually transmitted infections reduce the chance that the individual will develop this particular disorder. So definitely giving antibiotics will reduce the chance of development of these Reiters or reactive arthritis. And for chronic reactive arthritis associated with Chlamydia infection, a randomized trial demonstrated that 6 months of rifampicin in combination with either doxycycline or azithromycin was more effective than compared to that of the placebo. So, for Chlamydia infection, the antibiotic, right, the antibiotic that has to be supplemented is rifampicin, right? So, what will be the dosage of the rifampicin? This rifampicin should be given 300 milligrams twice daily, right? And this has to be given for nearly around 6 months, right? This has to be given for nearly around 6 months. And this rifampicin, it is given in combination with either doxycycline or azithromycin. So if you see the doxycycline, the dosage is 100 milligrams twice daily. Whereas the dosage of azithromycin, it is 500 milligrams orally daily for 5 days, then twice weekly. So 500 milligrams once daily for 5 days. So this is about the antibiotics that has to be supplemented in patients with reactive arthritis. Now, giving these antibiotics definitely will reduce the incidence of the Reiter's or reactive arthritis. And for suppose this arthritis, if there is no response to NSAIDs, then what are the alternative drugs? The alternative drugs include sulfasalazine, and methotrexate. Right, sulfasalazine and as well as the methotrexate. And for those patients with recent onset disease that is refractory to NSAIDs and these DMARDs, anti-TNF agents which are effective in other spondyloarthropathies may be effective. So in the sense, in those individuals who are not responding even to your NSAIDs and as well as the methotrexates, who are having recent onset arthritis, for them we need to give the anti-TNF agents. Alright, so definitely the drug of choice will be NSAIDs, but in those individuals who are not responding to NSAIDs, these will be the alternative drugs. So to summarize the entire Reiter's or reactive arthritis, so these are the essentials of diagnosis that includes the oligoarthritis, conjunctivitis, urethritis, keratoderma blennorrhagicum and the mouth ulcers. These are very common. And this Reiter's or reactive arthritis usually follow dysentery or the sexually transmitted infection. And HLA-B27 positive in almost 50 to 80% of patients. So these are the essentials in the diagnosis of the Reiter's or reactive arthritis. So you have to know that antecedent gastrointestinal or the genitourinary infection, the individual developing asymmetrical arthritis. Along with that, there is conjunctivitis and urethritis. One of the very important differential diagnosis will be Reiter's or reactive arthritis. Thank you very much.